Okay, good evening, everybody, and welcome to another program from the USI ISU. This is from the female and the functional urology subsection. Dr. Sanjay Sinha and his team have put in a lot of hard work to do this OSCE on the female urology. It's going to be a very important session for the days to come when this time the DNB had their exam based on the OSCE. 150 marks was based on OSCE itself. So if you're good at this, you can score a lot of marks in the OSCE because it's going to be like mathematics. You can score 100 out of 100 if you're good at that. So this is a good session. It will be a teaching session also. It's not only answering it. The experts in this would give you all the reasoning of the answers which are going to come later on in the second part of this OSCE. With this remark, I would now invite Dr. Rajiv Sood to give his opening remarks. Over to you, Dr. Rajiv Sood.
Thank you, Dr. Keshav. This is a great occasion. Again, for the third time, we are conducting OSCE-based program. Greetings from Indian School of Urology. And the National Board of Examination has given us the opportunity that we are introducing this as the regular feature, subspecialty based in our USI programs, resident programs. And OSCE is not only for National Board of Examination, but it is giving us insight of the subject, of the subspecialty, and this is the third OSCE program. Andrology and endourology has been done already, and this is we are doing today female urology, which is going to be conducted by Dr. Sanjay Sinha, Dr. Nikhil Khattar, Dr. Vasudevan, and Dr. Mayank and Panda. So this whole team of female urology and functional urology, which has prepared this program with hard work, is a sample only. It is the representative questions where we have endured to include the explanation and also the way of teaching and learning is explained in this OSCE program, as Dr. Keshav has rightly mentioned, that this is just like mathematics or Sanskrit. You can score 100% also in this. We are examiners in the OSCE is right from the beginning, and we have created some questions also for the national board, and we know that this will give us the opportunity both in DNB exams and also in MCH exams to learn the subject properly. Very good innovation which has been introduced by National Board and also now Urological Society of India. We are sure that residents are going to be immensely benefited today with under the able leadership of female urology and functional urology in the hands of Dr. Sanjay Sinha. He is leading today's program with all the pack of faculty. Let us congratulate them and also all the best to the residents, and be prepared for the answers which are to be given by the residents and later on explained by the and marked by the faculty. Thank you. Back to Dr. Keshav.
Thank you, Professor Rajiv Sood. I would now invite Dr. Arun Chawla to introduce the program and then hand it over to Dr. Sanjay Sinha.
Thank you, Dr. Thank you, Dr. Keshav. I think as Dr. Rajiv Sood has pointed out, this is the third OSCE for subspecialty of female and functional urology, a subsection of USI. I think I'll not share the details, but Dr. Sanjay Sinha has already, in his presentation introductory slide, has kept all the instructions, the way to handle the questions and the answers, and where to send. Everything is there in the introductory slide. I just want to wish you all the best for this OSCE. Thank you, sir.
Over to Dr. Sanjay Sinha to conduct the proceedings. Over to you, Dr. Sanjay.
Just one moment, sorry. Sorry, I'm just trying to get my screen. Okay, right. Yeah. Okay. Good evening, everybody. Thank you very much, Dr. Arun Chawla, Dr. Rajiv Sood, Dr. Keshav, for entrusting us with this important task. And I think over the last couple of years, especially, we've really had an acceleration of resident teaching programs with the online Zoom-based systems, which I think is extremely good for resident education, at least the theoretical part of the education. I think the practical part is a different issue altogether in these times. I will straight away start by sharing my screen, and I hope I can do that. Okay, OSCE questions, right. Sorry. Okay, I hope you're seeing my slide now. The OSCE in functional female. Can somebody confirm to me the right presentation?
Yes, sir.
Okay.
Yeah.
Right. Okay. So this presentation has been made along with contributions from all our team members, Dr. Anita, Dr. Pawan, Dr. Nikhil Khattar, Dr. Arvind Panda, and Dr. Mayank Mohan Agarwal. And I'm really deeply grateful to all of them for having put in an effort for making this session. So what are the instructions for today? Please take a clean sheet of paper and write down your name, your institution, and city on the top of your answer sheet. We will be presenting either short case details or a situation or a pictorial for you to take a look at. The questions typically require a very brief answer, and you do not need to provide any extra information. So if we've asked you, give us state two, let's say, facts or two reasons or one reason or three possibilities, just do that. You don't need to give us anything extra because you won't have time for doing extra. Each question carries 1 mark. So when I say each question, supposing there's a question in which it's mentioned, state 2 reasons for, then it would carry 2 marks. So every response that is required of you carries 1 mark. Please ensure that you write down the correct question number, and each question number will be indicated by 2 separate indicators. There'll be an alphabet which will tell us the case, and there'll be a number which tells us the sub-question. So it could be case A1, A2, A3, and so on. You need to send in your response sheets within 10 minutes of completing this OSCE to the, I'll give you the email address in a moment. And that's the email address, which I think all of you are already familiar with, the OSCE 2021 exams@gmail.com. So do send in your responses within 10 minutes to this. And in fact, the sooner you send in your responses, the quicker you'll be able to join us for what Anita is going to be anchoring. Dr. Anita Patel from Mumbai would be anchoring a program on mental health for the urology of the urologists and urology residents in the 10 minutes that we are giving you in between. So the quicker you do and send your answer sheets, the quicker you can join us for this, because we believe that this is an important 10-minute session that could be useful to all of us. So let me start off with the first case situation, and this is a male lower tract symptom situation. A 68-year-old male, a 68-year-old male has bothersome lower tract symptoms despite tamsulosin, 0.4 milligrams. He has voiding difficulty, frequency, urgency, nocturia 2 per night, no dysuria, hematuria. His urine exam is normal. Ultrasound scan shows a prostate 50 grams with a residual of 160 by 320 ml pre-void volume, PSA 1.5. His flow is 8 milliliters per second. What medication would you recommend next? So I'll just show it to you again. What medication would you recommend, for this patient who has a flow of 8 ml per second, PSA 1.5? He has bothersome lower tract symptoms despite tamsulosin 0.4 milligrams once daily. So you need to give us one answer of what would be the recommended medication that you would give next. This is question number 1A. Okay, we move on to the next question, 1B. Dutasteride was added to the tamsulosin. He continues to be symptomatic and mirabegron was added. Repeat tests at 3 months showed a normal urine exam, ultrasound scan 170 by 300 ml, a uroflow of 7 ml per second. What would you recommend for this patient? So this patient, again to re-emphasize, is on now dutasteride, tamsulosin, and mirabegron. He remains symptomatic with lower tract symptoms. His urine exam is normal. His ultrasound is 170 milliliters residue over 300 ml pre-void, a uroflow of 7 ml per second, what would be your recommendation to this patient? You go to the next part, 1C. If the patient had a gland size of 90 grams, what surgery would you recommend? If this patient had a gland size of 90 grams, what surgery would you recommend for this patient? Question 1C. The patient underwent a TURP and presented 4 months following a TURP with difficulty in voiding. After a few days of relief, the voiding symptoms, so he had initial relief and then the voiding symptoms recurred, and these are progressive. His urine exam is normal. His ultrasound scan shows normal kidneys, a prostate which is 11 gram in size, a PVR of 180 ml. His flow rate is 4 ml per second. What condition do you see here? And what is the most important risk factor for developing this condition following a TURP? So this is a patient who has had a TURP 4 months ago, had initial relief of symptoms, now has recurrence of symptoms. What is the most important risk factor for this condition following a TURP? So this concludes the first case situation that we had, and we will now move to the next one. So this one would be abbreviated as question 2. And the first part of question 2 is state 2 quality checks that you look for in a urodynamics trace. State 2 quality checks that you look for in a urodynamics trace. So as I said, each question carries 1 mark. So when you're stating 2 quality checks, this question carries 2 marks. Take a look at this urodynamics trace and mention 2 important findings in this urodynamics. Now, just to clarify, the top line here is P vesicle in blue. Blue is for bladder here. The red line, the next line is P abdomen, red for rectum. The third line here is P det. And the fourth line here is the flow. State 2 important findings in this urodynamics trace of a 60-year-old male. This place is where the permission micturition command you can see is given here. Okay. This next question is question 2C. 2C. Please make sure that your question numbers are right. Okay, so keep re-verifying in between. 2C. What is your impression regarding detrusor contractility and bladder outlet obstruction in this tracing of an adult male? So this is a tracing of an adult male. What is your impression regarding detrusor contractility and bladder outlet obstruction in this tracing? Once again, the top line blue is P vesicle, blue for bladder, red for rectum. The next line P abdomen, third is P det. This is the flow line. And I've mentioned here some of the important numbers so that you don't have difficulty in reading the numbers off the screen. The P det Qmax here is 55. The Qmax is about 3, and there's a post-void residual of 15 ml. The cystometric capacity is 301 ml. So your impression regarding detrusor contractility and bladder outlet obstruction on this trace. I have no way of knowing whether I am going too fast or too slow. So in case, Arun, maybe we can have one of the residents tell me, or maybe you can tell me whether I'm going too fast or too slow. You got experience with this. Or maybe Pawan, you can tell me. You think we are going by the right speed? I hope so. Okay. State 3 indicate. This is question 2D. State 3 indications for urodynamics prior to a TURP. State 3 indications for urodynamics prior to a TURP. This is question 2D. 3 indications for urodynamics prior to a TURP. Okay, a 72-year-old male. So this is, we go on to the next section, which is section 3. And these questions will be marked by the number 3 on male LUTs. A 72-year-old man with Parkinsonism has lower urinary tract symptoms, voiding and storage, despite Silodosin 8 milligrams, mirabegron 50 milligrams, with marked urinary frequency, urgency, incontinence, and nocturia. His uroflow shows a maximum flow rate of 10 ml per second. Flow rate is 35 grams, and his residual is 60 ml with a pre-void volume of 160. His urine exam is normal. PSA is 1 nanogram per milliliter. What would you do? I think I should have put this on the previous slide itself. So let me again put this here. So this is a man who's 72 years, has Parkinsonism, has storage and voiding LUTs despite Silodosin 8 milligrams and mirabegron 50, with marked frequency, urgency, incontinence, and nocturia. What would you do? Is somebody trying to communicate?
I think there is one call from Arjan. Anything? I think your internet is unstable. You are not able to communicate.
You can hear me clearly, Arun? My net is by.
Yeah, yes, I can. If you have any issue, please message us in the chat box, please.
Okay. A frequency volume chart showed 24-hour voided volume of 950 ml, 10 voids, a mean voided volume of 95, 3 times nocturia, and nocturnal urine volume around 300 ml. Solifenacin 5 milligrams was added. The patient was better for 6 months, but came back with an exacerbation of symptoms, but no cognitive deterioration. What would be your next step? So this patient was already on Silodosin 8 milligrams and 50 milligrams of mirabegron, had lower tract symptoms, storage as well as voiding, has come back on medication with an exacerbation of symptoms. What would be your next step? A repeat assessment in this patient showed ultrasound pre-void 150 ml post-void residue over a pre-void of 220, a flow of 5 milliliters per second in this patient. He's bothered by his symptoms. What would you do next? So this patient is on solifenacin 5 milligrams, Silodosin 8 milligrams, and mirabegron 50. His flow is now 5 ml per second. His post-void is 150 by 220 ml, and he's bothered by his symptoms. What would you do next? So with regard to urodynamics for refractory male lower tract symptoms in a patient with Parkinsonism, state 2 specific questions you would like to answer on the urodynamics trace. So if you were to do urodynamics in a patient with Parkinsonism who has refractory lower tract symptoms, a male patient, state 2 specific questions you would like to answer on the urodynamics trace. This is question 3D. Question 3E. State 2 important differences between the urological presentations of patients who have Parkinson's disease and multisystem atrophy. State 2 important differences between the urological presentations of Parkinson's disease and multisystem atrophy. This is 3E. We go to the next section, and this is with regard to neurogenic lower urinary tract dysfunction, or NLUTD. Name 2 conditions that by their very nature are regarded as high-risk neurogenic lower urinary tract dysfunction. So name 2 conditions which by their very nature are regarded as high-risk neurogenic lower urinary tract dysfunction. That means if the patient has that particular diagnosis, the patient would generally be regarded as high risk, regardless of all the other findings. So we start off with the basic premise that the patient has a high risk disease. Take a look at this trace of a patient who had a fall from height 12 years ago. He had injury to D11, D12, and I'll just play this video for you. So again, P vesicle, P abdomen, and P det. It says bladder filling up. Right, so this is a urodynamic video urodynamic trace of a patient with spinal cord injury. And the questions are, why did I ask that question? Just a moment. Is there a question here somewhere? Sorry. Oops. Okay, I'll understand later perhaps why I asked this. No problem. Otherwise, you'll discuss it even if I didn't have a question pertaining to it. Not an issue. Okay. 4C. So wait, hold on. So your question here is, what is your diagnosis in this patient? So the question is, what's your urodynamic diagnosis? 4B, what's your urodynamic diagnosis? So just in case you didn't see it well, I'll quickly run it again. So again, third line is the PDET line. And those are our findings. What is your diagnosis in this patient? Okay, 4C. What is autonomic dysreflexia? What is autonomic dysreflexia? For C, what is autonomic dysreflexia? For D, state 3 steps that you would take in the event of autonomic dysreflexia. State 3 steps that you would take in the event of autonomic dysreflexia. 3 steps in the event of autonomic dysreflexia. We know that autonomic dysreflexia is a very important condition everybody should be aware of if you're managing a neurogenic lower tract dysfunction. So as a urologist, an important condition to recognize, and you must know how to treat. So state 3 steps that you would take in the event of autonomic dysreflexia. Okay, take a look at this trace. Again, P vesicle, P abdomen, P det. That's permission to void of a patient with neurogenic lower tract dysfunction. Do I have a question here somewhere? Okay, so the question, this is question 4E. This is a 31-year-old male with neurogenic lower tract dysfunction. The question is this bladder safe? So the question is this bladder safe? Question 4E. Is this bladder safe? We go to the next section, and this is question 5 on female voiding LUTs. Look at this case detail. A 35-year-old male has a slow stream, straining and incomplete evacuation of urine, along with frequency and nocturia. She has recurrent urinary tract infections. There's no history of urgency, incontinence, or constipation. This is her flow rate, and you can see that the flow is very slow. This case is courtesy Dr. Nikhil Khattar, who's there in our program, and he can always give his comments during the discussion time. You can see here a very slow stream. Cystoscopy and urethral dilatation has been done thrice, and each time her symptoms improved for 2 to 3 weeks. But she had a recurrence. Local examination and focused neurourological exam are normal. The first question, state 3 causes of a slow flow in a woman. 3 possible causes for having a slow urine flow in a woman. This is question 5A. State 3 causes of a slow flow in a woman. This is the urodynamic trace for this patient. And you can see here, again, this is the P abdomen, the P vesicle line, that's P abdomen, and that's P det. That's the corresponding video film for this patient during the voiding phase. State 2 possible causes for getting this kind of an appearance during voiding in a woman. So this particular appearance that you got on the urodynamics, video urodynamics trace, state 2 possible causes of getting this appearance during voiding. This is question 5B. 2 possible causes for getting that appearance on the video aerodynamics during voiding. 5C. State any one criterion for making a diagnosis of bladder outlet obstruction in women. Any one of the criteria that are there for us for making a diagnosis of bladder outlet obstruction in women. Any one. Five C, any one criteria for making a diagnosis of bladder outlet obstruction in women on the urodynamics. 5D, what is the percentage probability that this woman with this presentation might be having a stricture? What is the percentage probability that this woman might be having a stricture? Five E, what is the probability that an optical urethrotomy or a dilatation will cure her stricture? What is the probability that an optical urethrotomy or a dilatation will cure her stricture? Five F, what is the probability that urethroplasty would cure her stricture? What is the probability that urethroplasty would cure her stricture? Oops. Oops. 5G. What is the probability that urethroplasty will cause iatrogenic stress UNI incontinence? What's the probability that a urethroplasty would result in iatrogenic stress UNI incontinence? Five H. When would you not consider using vaginal mucosal graft? So any one situation where you would not consider using vaginal mucosal graft for repair of a urethral stricture. That's question 5H. We go on to the 6th section, and this is based on the USI UNI Incontinence Guidelines of 2019. 6A, mention 3 baseline evaluations recommended by the USI guidelines for urinary incontinence in addition to clinical evaluation. 3 baseline evaluations recommended by the USI guidelines for urinary incontinence in addition to clinical evaluation. So other than clinical evaluation, 3 baseline evaluations recommended by the USI UNI guidelines of 2019. Question 6A. Three baseline evaluations. Each answer you give carries a mark, as I mentioned at the beginning. 6B. What is the recommendation with regard to urodynamics before injecting botulinum toxin for refractory urgency incontinence as per the USI guidelines? What is the recommendation with regard to urodynamics before injecting botulinum toxin for refractory urgency incontinence? Question 6B. What is the main reason behind this recommendation? What is the main reason behind this recommendation? This is, of course, there in the text of the guidelines. That's 6C. 6D. As per the USI guidelines of 2019, how is refractory urgency incontinence defined? So as those of you who have read, I'm sure all of you would have read it by now, might be knowing, refractory urgency incontinence was defined in the guidelines, and it was defined differently as compared to the only other existing definition for a corresponding condition, which is the definition for refractory overactive bladder by the AUA guideline. How was refractory urgency incontinence defined? As per the guideline, how is pelvic floor muscle training defined? There were 4 new definitions in the guidelines. There are questions in this quiz on 2 of them, but there were actually 4, and you should go back and take a look at the other definitions also, because knowing those definitions will actually give you a wealth of information about the condition. And the definition actually incorporates key parts of clinical care. So how is pelvic floor muscle training defined? That's 6E. We go to the 7th section. We have a total of 9 sections. The 7th section, and this is on storage symptoms. A 64-year-old woman was referred with urinary frequency, urgency, and urgency incontinence for 4 years. She had urgency or premonition before the leak, no constipation. She had been on escalating antimuscarinics and mirabegron with lifestyle changes, but she still needs 3 pads a day. Stress test is negative. She has no pelvic organ prolapse, and neurourological exam is normal. She has multiple small volume voids with multiple leaks, a 24-hour voided volume of 1.2 liters with a small average voided volume. Her creatinine is 1.6. She has no hydronephrosis. Looks like parenchymal disease. Normal urine examination. And the urodynamics showed tetruso overactivity incontinence with reduced capacity and early sensations with normal compliance. She voided reasonably well with a steady flow of 13 milliliters per second, no PVR, and a low pressure contraction of about 25 centimeters of water, but she completely emptied her bladder. Of note, in her symptoms, she only complains of storage symptoms. What would you recommend for this patient's persistent storage symptoms? So this is a woman with persistent storage symptoms despite conservative care and combination drug therapy for overactive bladder. She does not have stress incontinence on a clinical stress test, does not have any obvious neurological underlying abnormalities, and voids reasonably well. She's 64 years old. What would you recommend for her persistent storage symptoms? That's question 7A. 7B. She elected to undergo botulinum toxin injection. What dose would you recommend as the starting dose? What dose would you recommend as the starting dose? 7C. What is the expected efficacy for botulinum toxin injection for refractory overactive bladder symptoms? What is the expected efficacy for botulinum toxin injection for refractory overactive bladder symptoms? I must add in a woman. 7D. What is the expected rate of urinary retention in a woman? What is the expected rate of urinary retention in a woman? 7D. 7E. This patient had a partial response with botulinum toxin injection and also noticed some difficulty in passing urine after the injection, but she continued to be symptomatic. What would be your recommendation? She continued to be symptomatic despite the botulinum toxin injection. 7E. 7F, she elected to undergo sacral neuromodulation. Where would you like to position the electrical lead? Where would you like to position the electrical lead, the tine lead of the sacral neuromodulation? That's question 7F. 7G, how would you confirm the precise positioning of the lead? How would you confirm the precise positioning of the lead? How would you confirm the precise positioning, 7G? You go to the next section, the second last section, and this is on nocturia. A 65-year-old male who's diabetic has bothersome nocturia 4 per night, daytime mild frequency and urgency, which is not bothersome. No voiding difficulty, dysuria, or hematuria. It's been long standing. He has a BMI of 34, diabetic for the last 7 years, hypertension for 14 years, no constipation. A complete urine examination is normal. Diabetes is well controlled. Normal renal function tests. Ultrasound shows pre-void 280 ml, post-void 55, prostate 35 grams with normal kidney, and a flow rate of 12 ml per second with sustained flow. (8A), how do you define nocturia? How do you define nocturia? That's question 8A. (8B), how do you define nocturnal polyuria? How do you define nocturnal polyuria? How do you define nocturnal polyuria? 8B. Oops. Skip that. Okay. So after 8B, we next have 8D. You can skip 8C. So there is no 8C, right? Make sure there is no 8C, right? So you go on from 8B to 8D. This is the patient's frequency volume chart, and I will help you with this. So this is the patient's frequency volume chart. Take a look at this chart. That's the time when the patient woke up. That's the first record of the day. We don't take the first reading, you know, when you take this, you record from the second reading of day 1 up to the first reading of day 2. That's the time when the patient went to sleep at 9:30. His daytime volume is 960. His nighttime volume is 1190. And he has a nocturnal urine index of 45%. So we are not testing your skill in math. What 2 recommendations would you make for this patient? What 2 recommendations would you make for this patient? Question 8E. State 3 causes for nocturnal polyuria. 8E. State 3 causes for nocturnal polyuria. Three causes for nocturnal polyuria. stress urinary incontinence in a woman. So a 55-year-old woman presents with clinical mixed incontinence. She has dominant stress-induced incontinence, but also has urgency-associated incontinence. There is no voiding difficulty. She has no constipation. She has long-standing symptoms for years, no pelvic organ prolapse, a normal focused neurourology exam, 2 deliveries, both vaginal, uneventful, and she's postmenopausal for the last 3 years. She has normal vaginal tissues with a good pelvic floor strength. Her stress test on a clinical exam is positive. Her urine exam is normal, and her post-void is negligible. Her uroflow is normal. Her diary record shows 3 episodes of incontinence in a day, 1 with urgency and 2 associated with stress. A 24-hour voided volume of 1.2 liters and a mean voided volume of 150 ml. She's failed to respond to conservative measures, bladder training, and pelvic floor muscle training. What would be your next step? 9A, what would be your next step in this patient with clinical mixed incontinence who has failed to respond to conservative measures? Nine B, she has continued bothersome urinary symptoms despite treatment for urgency incontinence. What would you recommend? What would you recommend if she continues to have bothersome urinary symptoms despite therapy for urgency incontinence? That's 9B. Nine C. State 1 clinical and 1 urodynamic criteria for making a diagnosis of intrinsic sphincter deficiency. State 1 clinical and 1 urodynamic criteria for diagnosis of intrinsic sphincter deficiency. That's 9C. One clinical and 1 urodynamic criteria for making a diagnosis of intrinsic sphincter deficiency. Take a look at this urodynamic trace. Again, the top line is P vesicle, the second line in red is P abdomen, and the third line is P det, and that's the flow line. What is your diagnosis? What is your diagnosis? That's question 9B. Take a look at this urodynamic trace. 9E, again the same order of the traces. What is your diagnosis? Nine E, what is your diagnosis? Nine F, and this part is courtesy Dr. Anita Patel, who's here for the session, and in fact will be soon taking over in the interval in a moment for discussing mental health, as I said. This patient was noted to have urodynamic stress incontinence with an ALPP of 90 centimeters water, and she underwent a transobturator tape. She presented 1 year after the surgery with voiding difficulty and pain. Her ultrasound scan shows a residual of 330 ml with a pre-void volume of 300. There's no hydronephrosis. This is her flow rate. Or flow rather. What would your next step be? So this woman presents with voiding difficulty and pain. Her ultrasound shows a low residual. This is her uroflow trace. What would be your next step? 9G. Oops. Right. She underwent a cystoscopy, which shows tape going across and within the urethra. State 2 important complications that you would discuss with the patient before surgery. This patient has tape going across and within the urethra. State 2 important complications which you will discuss with the patient before you operate this patient. Question 9G. 2 important complications when you find tape going across and within the urethra. Okay, so that brings us to the end of the questions. And
request, just before you go to the Madam Anita Patel's program, third question, if you can repeat for the our residents, they were having some problem in answering because question a little long. Third question, sure. Yeah.
Okay, just give me a moment. This is the third one. Okay, so we are repeating question number 3. Okay, we're repeating. Oops, there's some problem with my. Okay, we're repeating question number 3. A 72-year-old man with Parkinsonism has lower tract symptoms, voiding and storage despite Silodosin 8 milligrams, Mirabegron 50, with marked urinary frequency, urgency, incontinence, and nocturia. Flow rate of 10 ml per second. Ultrasound shows prostate 35 grams, residual 60 milliliters on a pre-void volume of 160. Urine exam is normal. PSA is 1. So has both voiding and storage symptoms, but dominant storage symptoms here is already on Silodosin and Mirabegron with a flow rate of 10 ml and a residual of 60 by 160. What would be your next, what would you do? That's 3A. 3B, a frequency volume chart showed 24-hour voided volume 950 ml, 10 voids, mean voided volume 95, 3 nocturia episodes, and nocturnal urine volume about 300 ml. 5 milligrams of solifenacin was added. The patient was better, but came back with marked exacerbation of symptoms without any cognitive deterioration. What would be your next step? So the patient is on solifenacin, Mirabegron, and Silodosin, and the patient has deterioration. What would be your next step? Repeat assessment showed pre-void, post-void 150 ml over a pre-void of 220, a flow rate of 5 ml per second. He's bothered by symptoms. What would you do next? (3D), state 2 specific questions you would like to answer on urodynamics in a patient with Parkinsonism, a male patient with refractory lower tract symptoms. State 2 specific questions you'd like to answer on the urodynamics. E, state 2 important differences between the urological presentations of Parkinson's disease and multisystem atrophy. 2 important differences between the urological presentations of Parkinson's disease and multisystem atrophy. You know, this is a very critical difference that you must make. So write down your name, your institution, your email and mobile at the top of your page, and please send it within the next 10 minutes to the usual email address that you've been sending to OSCE2021exams@gmail.com. And with this, I hope Anita is there. Anita, are you there? Can you switch on your video? So we would now be having a brief, interesting session, which Dr. Anita Patel from Mumbai is going to anchor on mental health of the urologist and the urology resident. And so let me stop my screen share and hand this to Anita. And Anita, perhaps you can start with the urologist so that, you know, by the time you reach to the urology residents, the residents would have sent in their answer sheets, and they would have the opportunity to be able to participate and listen in this. Over to Anita.
Right. Hi, Sanjay. Can you see my screen now?
Yes, we can. Yes.
Yeah, great. Okay. So at the outset, thank you so much, Sanjay, for asking me to entertain. I stumbled on that word and I thought, why not do something which is very important during the pandemic? And I must admit the trigger for that was the West Zone newsletter, which focused this time on the mental health of urologists. And it's a fabulous newsletter. I would recommend everybody to go on to the website of West Zone Urology Society of India and do read that newsletter. So coming to our session, I felt why not have something like an open discussion? And many of these questions or situations that I would be describing, I'm going to be throwing them open to anybody from amongst the faculty who would want to take that question. So why mental health? The whole world is talking about mental health, and what is so special about urologists? So some very standard areas which lead to worries, especially during the pandemic. The first worry is, of course, financial, because there is a drop in workload. Next being, there is a health scare of us receiving COVID. Many of us are seniors and semi-seniors. We've reduced our work, we've stopped our work. And then there could be domestic stress, which could be due to a family member who may be down with any other ailment, or family members who could be down with COVID. Some of us have lost our near and dear ones to COVID. For junior urologists, the issue could be kids being at home, their online education, and both parents working and having to do hospital duty, a very stressful situation indeed. For the middle-aged people, I mean urologists, their kids could be studying abroad, and there is a major burden of looking after their education fees. And a very interesting situation which many of us have gone through, and that is kids getting married abroad, having their weddings online and parents sitting and clapping from sitting in India. This is a stressful situation indeed. So I would really throw open these situations to all the faculty. Please, take the liberty of raising your hand and saying that, yes, I would like to take this question. So anybody who's working in the government sector, I have just highlighted some of the areas which I feel are important. I have discussed that with the HODs of teaching institutes in Bombay for sure. The first and the foremost being, of course, the dropping workload. Due to a variety of reasons, I don't have to go through that. There is increased admin work for the head of the department. There is a burden that the trainees are getting less and less work, because the prioritization and only urgent work being done, etc., etc. There is, of course, an issue of trainees being unhappy because they have to do COVID duties. Look, all of us have been through our MBBS, our MS. Now we have joined MCH or DNB urology. The last thing on my mind is to do COVID duty. I do want to learn how to put a difficult DJ stent, how to do a ureterotomy, how to do a laser enucleation, so on and so forth. And the exams are getting postponed. So that is very stressful. And being the head of the department is the worst situation. So maybe I could get the ball rolling. Maybe Pawan, would you like to just, tell us from your department, was any of this a concern? And did you, as a senior faculty member, have to address mental health issues affecting either the faculty members or the trainees? Would you like to comment on that, Pawan?
So, ma'am, the first point, dropping caseload, our department, the urology theatre was closed for nearly 1 year.
Yes.
Because the whole facility was converted to a COVID facility. So the department practically shut down from a urology perspective for a year, operative-wise. Then nearly more than 50% of all our residents and 30% of faculty at some time contracted COVID themselves. So even though most of us were vaccinated and so on and so forth, but the vast majority have, they all got COVID. Then trainees getting very little work, absolutely correct, because what they were supposed to do in their first year, they're now doing in their second year. People who had to, who graduated, they graduated with doing very little work. So yes, overall it's, but it must be like that for, I mean, at all places.
Yeah,
But
so my specific point, Pawan, is was there any mental health related issue that you kind of faced, both from your faculty point of view, maybe the staff, even the non-medical, the paramedical staff in the department, and what about the postgraduates? You know, that is, the whole idea was to focus on the mental health. And was there a situation that maybe you would want to narrate, or how did you navigate that?
I think the stress came from most of us getting pulled into COVID duties, you know, without knowing anything about respiratory care, and at the end of a couple of months, all of us felt that we are trained actually to, you know, to treat COVID. So that transition where people started getting posted, started managing COVID, that was probably the only thing which was stressful as far as my department was concerned.
Was it easy or difficult to handle the trainees? They would be irate, and of course there's no hands-on work, and there is too much of respiratory physiology going down your brain. So
we have a good batch of trainees, and most of them, you know, everybody knew.
All trainees are good, Pawan. All trainees are good.
No, I mean, so everybody
at least to our faces.
Yeah. So everybody knew there's not much you can do. So everybody, I mean, collectively managed to sail through.
Right. Anybody else from the faculty present today? Is there anything that you would like to add? Because yes, there has been a lot of mental illness, and people have actually, you know, gone into a panic mode, anxiety mode, and the psychiatrists have reported a major increase in their patient footfall. So anybody else, maybe Sanjay, do you have a comment, or Dr. Keshav Murthy, anybody?
Maybe Keshav,
Yes.
we can go first.
Yeah, I think the dropping caseload was a concern, but luckily for my institute, it was not a COVID institute. So although they were dropping the case, we continued to do the urology work, but the stress was that I was doing the admin work and managing the dialysis unit in the COVID hospital. We had to put up a dialysis unit, and getting the trainees to go there and work, especially the nephrology postgraduates, was a real stressful, because they were very hesitant to go and do COVID duties because they were nephrology residents and they would not do anything other than COVID duties. So we had to convince them and talk to them, and they agreed to that, and we managed that. The trainees getting very little work is a concern. Definitely a concern, is because they are used to operating so much in a government hospital, and when you suddenly feel that you are not doing anything. In Victoria Hospital, if you see a surgery resident who has joined last year, would not have done anything because the whole hospital is a COVID hospital. His exposure to surgery is only the emergencies which they get in because of the COVID. Other than that, he would not be exposed at all to general surgery.
Did any of the trainees kind of break down, or did they actually express the need for mental health?
Our postgraduates did not have that problem because they were continuously in urology duties, only very rarely in a COVID duty. But yes, the general surgery residents have actually protested, done all those things, is because they were thinking that the general surgeons, the orthopedic surgeons, were not supposed to do these duties, and their work has been taken off. So convincing them is a stressful job.
Yeah. So maybe let's now switch gear and go to the corporate sector. And Sanjay, I know you do work in corporate sector. You need not, comment on the points that I have raised, but I would just like to listen to your perspective. Keep in mind, this is from mental health point of view. Is there anything that you felt was not right?
So I think some things which immediately come to mind is that working has become actually present tense, present continuing tense. Working has become exhausting, and I use an N95 and a shield in the OPD, and I've got my patient sitting 6 feet away. So in the beginning, after a few days, I realized that by around 11:30, 12, I was losing my voice because I doing a busy OPD, and it became very difficult. So now I actually use a small mic. So I have a mic and I have a speaker on my table. and I use a mic, and that mic goes into my pocket when I go for the OPD, for my rounds and so on. So I'm actually constantly using a mic in the hospital now. But even otherwise, I think it becomes exhausting. And when we're exhausted, we're on a short fuse. So I find, for instance, for the first time, or maybe it's very rarely happens, there was an elderly gentleman a few days ago who got up at the end of the consult, not on the first day. He came back for a review on the second day. And there was something off when I was speaking to him. And at the end of everything, he got up and said, "Doctor, for the first time in my life, somebody spoke to me so harshly." And I was taken aback. And I really was shocked by he said, "Nobody has ever spoken to me this harshly the way you have spoken to me in my whole life." And I'm typically, I try at least to be very soft with my patients. And I was really taken aback and felt bad about it, actually. And I don't know whether I was really able to make amends for what he felt was a harsh statement. Because I tell my patients, sit down, don't come close to me, keep all your papers with you, we'll pick up the papers from you, just sit there. And I don't want them coming close to the table, but he misinterpreted that. And through the mic, it became magnified when I spoke. So anyway, it's been tough, including things like, personally for me, it may not have been such an issue, but I do know that dropping case workload, especially, periods when you have less work, you need to have buffers in your finance, because most of us are on kind of daily wage. We are daily wage workers and glorified daily wage workers, not on a salary. So clearly it's tough, but I think let's go to the nursing home, because we also need to get back to our presentation. So I'm going to allow you to.
I mean, I highlighted some of these points because I operate from a nursing home setup, and it's been stressful. Apart from the standard stress, the staff's not reporting to work, the staff's having family members falling ill due to COVID, and actually requesting for mental health professionals' help. And I have never had to do that in last, say, 25 odd years. And this is for the first time that I actually saw the staff breaking down their kids' education. And this is the non-medical staff, the paramedical staff. And we as urologists are not really trained or geared to deal with this. And this is where I felt that somewhere I'm falling short and I need professional help. And I felt this is where maybe we could do a pan-India urological mental health survey. I know that is being done in general surgery. I know that is being done in OBGYN. And the way the pandemic has hit, I felt the time has come to do some kind of survey. And maybe there is a separate cell of USI to deal with the mental health issues of urologists. If there isn't, then maybe this could be the beginning, that we could have a separate cell. And also, I feel a separate team looking after the mental health of trainees, who I feel are the worst victims of this entire COVID scenario. I would appreciate anybody to make a comment before we wind up, because in a 10-minute session, we could only do so much. However, is there anything particular, maybe Dr. Chawla, maybe Dr. Sood, please feel free to comment, and the input, I believe, would be invaluable both for the practicing urologists and for the trainees. So over to anybody who wishes to make a comment on this.
Madam, can I just speak about this?
Yes.
Arvind here. I'd just like to say 2 points. One is there has been a lot of work on this internationally. It's not just today that we are seeing. Urology as a subject has a very high levels of burnout. And I wrote editorial in the IJU a few months back on this about burnouts among urologists, and the very nature of the profession, where you have to deal with a very high turnover of patients and high patient expectations of cure, makes us susceptible, and the rates of suicide among urologists in the West are the highest among any health professional. Any health professional that you will find. As coming back to the COVID thing, there were extraneous pressures, but I do not think the residents, apart from the COVID duties, they were very worried about the COVID. They were upset about the COVID duties, but most of them did them well. They understood about some time in the pandemic that this is something which they cannot avoid, and they might as well do it well. And now that the COVID thing has come down and the caseload also has gone up, I think more or less that wave may settle. But inherently, urology as a field seems to be very susceptible to suicide. It seems to be more susceptible to burnout. And
fair
this
enough,
has been
Dr.
found
Pandya. We will
banned
just check.
in
We
the
will
world.
just check with Sanjay if we have any more time for anybody else's comment, or we need to wind up, because I just wanted to introduce this concept primarily to USI. Sanjay, let me
Dr.
know
Anita,
if
Dr. Anita, there is one response from the viewer. Can you take the response?
Okay. Yeah.
One response from viewer. Sadhvi, can you please unmute yourself? Yeah, please unmute.
Quick comment.
yes, I actually cannot see that, and I'm getting a message from Sanjay saying that we're running short of time because we need to discuss.
So this obviously can't be the forum for doing a detailed discussion on
Absolutely.
this, but I think the good part is that we've started a conversation in this regard.
I'm going to stop sharing my screen.
Always there. Yeah, mental health problems are always there. It's not something new. It's just that it was under under the surface, but now it's actually we are discussing. Okay, I'd request all the residents to keep your mic mute so that we don't get your household sounds here, and we'll move on with the answers now. So let me share my screen again. Where is it gone?
Dr. Sanjay.
Can you hear me?
Yes, Sanjay, we can hear you.
Okay. I've lost that presentation. I'm searching where it's disappeared. Just give me a moment.
Sanjay.
Yeah,
Dr. Sanjay.
Yeah, I can hear you. Can you hear me?
We can hear you.
Okay. I thought I'd lost you for a moment. Okay, right, sorry. Right, so we'll run through the answers quickly. Okay, sorry. Okay, so this was the first situation that we were looking at, and this was a 68-year-old male with bothersome lower tract symptoms despite tamsulosin. He has difficulty avoiding difficulty, frequency, urgency, prostate 50 grams, PVR of 160 by 320. The question was, what medication would you recommend next? Well, you can improve his voiding dysfunction with improvements and resultant improvement with both voiding and storage. Changing the alpha blocker is unlikely to make any major difference. So moving from one alpha blocker to another is unlikely to benefit. But adding a 5 ARI is a reasonable thing, but it takes time for the effect to come. This patient has a gland size above 40 grams and a PSA of more than 1.5, both of which are criteria by which you could prescribe 5 ARI for this patient. The other approach would be to improve his storage symptoms by adding mirabegron. So what are the possible answers? Because this patient has both storage and voiding symptoms which are bothersome. The possible answers could be addition of 5 ARI, which is fine if that is what you have chosen. Addition of mirabegron is also fine. And acceptable would also be an addition of a PDE5 inhibitor. A combination of PDE5 inhibitor with alpha blocker is well tolerated and superior to alpha blocker alone, with improvements in the IPSS. But remember, when you give a PDE5 inhibitor, typically the improvement in IPSS is not matched by an improvement in the flow rate. So we don't really understand voiding symptoms that well, because there is improvement in voiding symptoms without an improvement in the flow rate typically. And not acceptable here would be the addition of an antimuscarinic because of the large residual. So many guidelines suggest that if the residual is above 150 ml, for instance, you should not use an antimuscarinic. So antimuscarinics would not be a preferred answer here, but all of the others would be acceptable answers if you have marked any of them. The next question, dutastride was added. He continued to be symptomatic. Mirabegron was added. Repeated tests showed this picture. And the question was, what would you recommend for this patient? And in this patient, it is reasonable to recommend a TORP at this point. So this patient is having significant voiding, significant problems with voiding despite medication. This patient is already on tamsulosin is taking dutasteride, is having a large residual and a slow flow with poor voiding efficiency, it's reasonable to offer this patient a TURP. He doesn't have any significant high risk features to suggest that you should do a urodynamic evaluation, for instance. So it's reasonable to offer a TURP for this patient. What are the acceptable alternatives? Any standard prostate surgery techniques acceptable, except a transurethral incision of the prostate, which would not be a preferred procedure for somebody with a 50-gram gland size. If his gland size was 90 grams, what would you recommend? This is easy. I'm sure we started off with an easy set of questions. Enucleation with any standard technique, bipolar or laser, a bipolar TURP or an open prostatectomy, all are acceptable answers here. Minimally invasive simple prostatectomy is an acceptable alternative, but you might have just difficulty justifying this in the examination unless you can really show that you are working in a unit like that. And very often examiners don't like if you give those kind of answers in the exam, so you need to be careful. So this patient presents 4 months following a TURP with voiding difficulty. And remember, we mentioned that the patient had improvement followed by deterioration. That's a good clue, because if you have improvement followed by deterioration, often that's a clue to the development of a contracture, in contrast to a patient who has failed improvement, which can be incomplete resection, for instance. So this patient, as we said, has had a very poor flow. That was the RGU picture. And you can see the contrast going almost up to the bladder neck. This patient has a bladder neck contracture. We'll accept if you say that there's a stricture, but the block that you are getting in the contrast looks to be above the level of the sphincter, seems to be at the level of the bladder neck and close to the bladder neck. So it seems unlikely that this would be a regular stricture. It looks like a bladder neck contracture. What's the important risk factor for this condition following a TURP? The important risk factor is a small prostate. So if you have a small prostate and you resect doing a complete TURP, you're more likely to produce this condition, which is why for small prostate glands, often a transurethral incision is a safer procedure, which results in less chances of getting a bladder neck contracture. This patient had a severe bladder neck contracture. This is a Nichols case material. You can see a guide wire placed across and an incision given. State 2 quality checks that you look for in a urodynamics. These are some of the quality checks, zeroing to the atmosphere, not to the patient. I'll show this in a moment. Plausible baseline resting pressures. Again, I'll show it in a moment. These are the plausible range of pressures that you expect. Periodic cough, one at the beginning before permission to void and at the end, and matching the fine trace between P vesicle and P abdomen. And I'll just show this to you in a moment in this trace here. You can see here the resting pressure should be in the plausible range. You can see a cough at the beginning, periodic coughs, a cough before the patient is given the command to void, and a cough at the end to make sure the transducers are working well. Fine trace match, you can see some fine traces here as the patient talks, walks, moves around, talks or moves around and so on. And you can see them matching well and subtracting out. And that's a permission to void. You can see steady changes, good subtraction. Right. State 2 important findings in this urodynamic trace. There are several findings here, and any of them could be fine. So this patient has a reduced capacity, reduced compliance. So you can see here that the end fill volume is about 160 and the end fill pressure is about 40. So compliance of 4 obviously is markedly reduced compliance. There's no neurogenic detrusor activity, or no detrusor activity, I should say. There's an acontractility, and this patient didn't void. And in the right setting, this could be an indication of an acontractile bladder, but it could also be a patient who never cooperated. So any of these 2 findings from this should be fine. Remember, of course, that each of these findings comes with a caveat, and we are not discussing the caveats of the findings here. So we are not discussing the caveats of making a diagnosis of acontractility, but these are the findings that you find here. What is your impression regarding this particular trace? And we asked you about bladder outlet obstruction and contractility. This patient has bladder outlet obstruction. You can see here why, because the bladder outlet obstruction index, which is calculated as the PDET Q max minus 2 times the maximum flow rate. So that here is 55 minus 6, which is 49, which is unequivocal obstruction. Anything more than 40 or 40 and above is unequivocal obstruction. 20 to 40 is equivocal obstruction. Less than 20 is not obstructed. The contractility, this patient is having an underactive detrusor, because you can see the BCI is 55 plus 15. So that's the PDET Q max plus 5 times the Q max, and that's 70. Less than 100. And 100 is the cutoff for a normal contractility. So patient has bladder outlet obstruction, unequivocal, with an underactive detrusor. State 3, indications for urodynamics prior to a TURP. You can choose any of these: age less than 50, age more than 80, a large PVR, high flow but symptomatic voiding difficulty, so what we call the so-called high flow obstruction, a neurological condition such as Parkinson's disease, abnormal focused neurological examination or suspicion based on history. So when I say here neurological findings or bowel symptoms, clearly somebody who has a little bit of constipation doesn't constitute suspicion of neurogenic dysfunction, but somebody say with a profound constipation, passing stools once in a week, for instance, that could be the clue, and you might want to examine such a patient. A patient who is unable to produce a valid uroflow volume. So repeatedly, the uroflow volumes are subnormal and you're not able to draw conclusions for it. Dominant storage symptoms with good voiding efficiency typically goes hand in hand with the previous one. And sometimes it's just a specific concern on the part of the patient who asks the question, is my bladder okay, will I pass or not? Or on the part of the urologist based on the patient's urologist assessment of this patient. And that sometimes leads to a urodynamics evaluation to assess the odds that the patient will be passing well after a TURB. So any three of these should be fine in your answer. Next section was Baylor's, Parkinsonism with storage and voiding symptoms, patient symptomatic despite the silodosin and mirabegron, and with a flow rate of 10 ml and a residual of 60 by 160. And what would you do? The preferred answer here is ask for a bladder diary or a frequency volume chart, because this patient has marked storage symptoms. What is an acceptable answer? It's acceptable to say that you would add an antimuscarinic with caution for cognitive dysfunction. This patient had the addition of solifenacin, was better for a few months, came back with deterioration but no cognitive dysfunction. What would be the next step in a patient who is having deterioration despite full medical management? In a sense, you can say that this patient is on all the medical management you can give. The preferred answer here is reassess voiding efficiency by an ultrasound and uroflow in a patient who is having deterioration, because you want to see the patient was voiding better earlier. Is the patient voiding well now after the solifenacin has been added? An acceptable answer to say that you'll plan straight for a urodynamics in this patient. Repeat assessment showed this, a large residual with a slow flow. He's bothered by the symptoms. What would you do next? Here the answer is, a preferred answer is video urodynamics or urodynamics with fluoroscopic monitoring. These are acceptable answers. Acceptable answers, urodynamics. What is not acceptable is to proceed with a TURP in a patient with Parkinsonism with this kind of a background, because some of these patients may not void properly, and we'll come to that in a moment as to why. D was state 2 specific questions you like to ask on the urodynamics. And this could be, how severe is the storage abnormality in this patient? Is he obstructed? Is detrusocontractility adequate? And is there any dyssynergic sphincteric activity, which you might expect in allied conditions, which we'll come to. E, state 2 important differences between neurological presentations of Parkinson's disease and multisystem atrophy. The onset of lower tract symptoms in Parkinsonism typically occurs years after the motor symptom. That means that the neurological symptoms antedate the urinary symptoms, but usually by many years. In multisystem atrophy, the urinary symptoms might herald the development of multisystem atrophy. So it might be the first symptom or early in the course of disease. Usually with Parkinsonism, the primary symptoms is OAB symptoms and storage symptoms and some element of voiding difficulty. Retention is not very common. Multisystem atrophy patients are more often present with retention. In urodynamic findings, the key difference is that patients, while in both have neurogenic detrus overactivity, you may have some impaired bladder neck relaxation, delayed sphincter relaxation, what we call the so-called bradykinesia, but you get true detrusor sphincter dyssynergia and multisystem atrophy, and often with poor bladder contractility. And because of these two findings, patients with multisystem atrophy very often perform poorly with a prostatectomy, and it's almost like a contraindication if there is multisystem atrophy to operate the patient for a prostatectomy. Neurogenic named 2 conditions regarded as high risk. Any of these, spina bifida, spinal cord injury, are both high-risk conditions just by their presence. Anorectal malformation is the third condition. And then any other neurogenic lower tract dysfunction which has high-risk features. So if patient has secondary VUR, development of hydrouretronephrosis, unfavorable features on urodynamics like poor compliance or high-pressure detrus overactivity, all these things will suggest to you that the patient is high-risk. But we were chiefly looking for one of these two, spina bifida, spinal cord injury, or anorectal malformation. On this trace, what is your diagnosis? So I don't know whether I mentioned it here. I'm not certain what I did. Maybe not. All right. So this patient, as you can see, has reduced compliance, has neurogenic detrusor overactivity, super added on that. There's a high end fill pressure. There's spontaneous rectal contraction artifact here. This is just an incidental finding. The patient had detrusor sphincter dyssynergia, which if you remember, I'd shown, I'll show it again in a moment. No volitional detrusor contraction. Let's see if I can show you that dyssynergia again. So you can see here, gross dilatation of the urethra with rises in bladder pressure. This patient is having detrusor sphincter dyssynergia. What is autonomic dysreflexia? A sudden and exaggerated autonomic response to stimuli below the level of lesion in patients with a spinal injury, which is at a high level of T6 and above, is defined as an increase in systolic blood pressure of more than 20 millimeters of mercury and can be catastrophic. If you have mentioned as an exaggerated autonomic response with high blood pressure following stimulation below the level of the injury, that is adequate for you to get the mark here. Typically, patient has headache, blurry vision, stuffy nose, pyeloerection, flushing and sweating above the level, and pale and cold skin below the level. State 3 steps that you would take in the event of autonomic dysreflexia, very important also from a practical point of view for your patient management. Loosen the clothes, empty the bladder or the rectum, take care with disimpaction, and use of antihypertensives. So these are the 3 important steps. Immediately you loosen the clothes of the patient, empty the bladder. Let's say you're doing urodynamics, empty the bladder straight away. Or if the patient has this problem at home, then ask them, is it getting triggered by the rectum being full or the bladder being distended, and make sure that you give them instructions accordingly. This was a tracing in which we asked you a question whether the patient is safe or not safe. The answer was, the preferred answer was you don't have enough information. So just by the reason why I put this here was often you will find people judging the safety of a patient based on just the urodynamic trace, and that is not adequate. You cannot draw conclusions regarding safety just by the UDS. The converse is true. You can look at the UDS and say that the patient is unsafe, but you can't say that the patient is safe just on the basis of the UDS. An acceptable answer here will also be that the UDS shows apparent safety, but needs to be combined with other information. So this is not enough to draw conclusions. What are the other findings here? The patient has normal capacity, apparently normal compliance, no NDO, some spontaneous rectal activity, a low end fill pressure, acontractile, but no PVR. So apparently seems to be safe, but let's look at the video tracing of the same patient and you'll understand in a moment why this patient is not really safe. So you can see here that this patient has large volume reflux happening. So what seems to be a safe storage is not really safe storage because a large part of the volume is being siphoned off into the upper tracts and the pressures are hence low. And then when the patient strains to pass urine, you can see here that there's a dilatation of the proximal urethra. This patient is in fact having dyssynergia with gross reflux, and what appears to be a safe bladder is not truly a safe bladder. So a classical situation where it shows you clearly that just the fact that this patient apparently shows a normal urodynamic trace or at least low pressures doesn't mean that the patient is safe. And this patient was unfortunately allowed to void through the whole of his life, and at 31 years has come with a creatinine of 5. Okay, so, next question, female voiding dysfunction. These are case details of a patient who had a slow stream, Dr. Nikhil's case. You can see here that the patient had multiple dilatations earlier, 3 causes of slow flow in a woman. In general, this is a general question of slow flow. Any of the 3 answers from here will be right. Underactive detrusor, bladder outlet obstruction secondary to pelvic organ prolapse, not uncommon. Bladder outlet obstruction due to dysfunctional voiding. Iatrogenic obstruction if the patient has had stress incontinence surgery. Urethral stricture, primary bladder neck obstruction. All these can produce, and occult neurogenic dysfunction, of course. All these can produce a slow flow in a woman. Any answers from this would be fine. This was the tracing that he had shown, and I asked you based on this tracing, what are the 2 possible causes for this appearance on the urodynamics? Bladder outlet obstruction due to dysfunctional voiding. So you can see here that the patient has a dilated proximal urethra, high voiding pressures. So the bladder patient is obstructed with a dilated proximal urethra. 2 possible causes of bladder outlet obstruction due to dysfunctional voiding, iatrogenic obstruction secondary to SUI surgery, and a urethral stricture, provided the stricture is passable. So if the stricture is not passable and you can't put urodynamic tubes because the urethra is very tight, then you can't do the study at all. But if you have a passable urethral stricture, then obviously you can get this kind of finding. Occult neurogenic dysfunction, of course, with dyssynergia can produce the same findings. state any one criteria for making a diagnosis of bladder outlet obstruction. This is not very standardized, but so any of these should be fine. So if you are close to these ranges, you are fine. So a ped Qmax more than 25 and a flow rate, ped max more than 25 and flow less than 12. So even if mentioned 22, 20, 28, 26, all that is within the range, just to show that these pressures are very different from a male patient for making a diagnosis of obstruction. Image-based criteria in women with a history of voiding difficulty is another criteria. And the Solomon-Greenwell nomogram, more recently given as ped Qmax minus 2.2 into Qmax, is another way of defining obstruction. So any one of these should be fine, or anything close to this should also be fine for us. What is the percentage probability she might be having a stricture? So the percentage probability is less than 10% of women who have bladder outlet obstruction. So we're not talking of all women with voiding difficulty, many of whom have underactive detrusor. So it's definitely less than 10%. And it's difficult to give a percentage on this because you will have a lot of variation based on case series and you don't have that kind of data, good data. But definitely less than 10% certainly. So if somebody's marked more than 10%, that would not be acceptable. So strictures are not that common. That's what we would like to tell you. That is the cystoscopy, and you can see urethroscopy rather, as Michael would say, and you can see here that there's a narrow urethra. What is the probability that another optical ureterotomy? The question answer is almost there in the question. The probability of having a response with another dilatation or optical ureterotomy, as you might guess, is very less. Most literature suggests less than 10%. What is the probability that urethroplasty cures a stricture? The answer here is 80%, but remember this is short term. With all strictures, there is a lot of attrition in the long-term success rate. And success is an entity that needs to be defined. So when you say success, always ask yourself, what do you mean by success? Is it objective success, subjective success? Are you talking about residual urine flow rate? What are you talking about? Patient satisfaction? Each of these will yield a different answer. But the ballpark figure about 80% in a recent review in the short term. What is the probability that urethroplasty causes iatrogenic stress incontinence? Less, about 5%. So it's not common. So this is one of the things that we're always scared about when we operate, but this is very uncommon, and especially because you go from within the sphincter mechanism, you don't actually go through the sphincter mechanism. You usually should not ordinarily produce iatrogenic stress incontinence. When would you not consider using a vaginal mucosal graft? In postmenopausal women where you have vaginal atrophy. You would not like to use vaginal mucosal graft for reconstruction in such a setting. Go on to the next section, USI guidelines. 3 baseline evaluations recommended in the guideline in addition to clinical evaluation: degree of bother, voiding diary, post-void residual, and a urine examination with different levels of evidence and grades of recommendation, which you can take a look at. Any 3 of these should be fine: degree of bother, voiding diary, post-void residual, and complete urine exam. What is the recommendation with regard to urodynamics prior to invasive botulinum toxin therapy? In the USI guidelines specifically, there's a recommendation for invasive urodynamics in men and women prior to invasive therapies for urgency incontinence. This is different from the other guidelines, which is why I brought it here. None of the other guidelines actually require this except our guideline. And the main reason for this recommendation is this one, that alternate diagnosis in patients referred as urgency incontinence is not uncommon. So for the reason that patients who are presenting as so-called urgency incontinence, it's not uncommon to find that they actually have elements of obstruction and so on. And in our guideline, once you make a diagnosis, like a label of refractory urgency incontinence, it permits you to put, say, a sacral neuromodulation. The last thing you want to do is to put a sacral neuromodulation in somebody who has an alternate diagnosis, or a botulinum toxin in somebody who's obstructed. Hence, in our guideline, we recommend the use of urodynamics, not because it improves the outcome of the procedure in the average patient. How is refractory urgency incontinence defined? Again, there's a specific differences in the definition, which I've highlighted in yellow here. These are patients who have an unsatisfactory response to drug therapy, including combination therapy, which is not there in the AUA definition. Doesn't make sense today to have a definition of refractory when you have not used combination. So the other international guidelines do not require you to have combination therapy. And the other is that avoiding diary has to be scrutinized before you make a diagnosis. Once you make a diagnosis, you can even put a sacral neuromodulation. Last thing you want to do is to put sacral neuromodulation in somebody who produces 5 liters of urine in a day. So this is part of the definition, a requirement, a guideline requirement. If you make a diagnosis of refractory urgency incontinence and you're planning to inject botulinum or you're planning to put a sacral neuromodulation, you have to scrutinize the voiding diary. How is pelvic floor muscle training defined? Again, practical relevance. The main part here, again, highlighted in yellow in the definition, that all the things that you teach the patient need to be verified by clinical exam. If you've just told the patient that's not pelvic floor muscle training under the USI guideline. So you need to verify by clinical examination that the patient contracts the right set of muscles, because 50% women don't contract the right set of muscles. And you also need to verify with the other hand that the patient does not contract other muscles at the same time. So that can be done very easily without the need of any special equipment, but has to be verified by clinical examination as per the guideline definition. Storage symptoms in this woman who has refractory urgency incontinence, despite use of mirabegron and antimuscarinics, and voids reasonably well. I asked you, what would you recommend for the persistent storage symptoms? So in this patient, botulinum toxin would be the preferred answer, or you could say, I mean, either of these two, botulinum toxin or sacral neuromodulation, are preferred answers. Either of those two are fine. Percutaneous tibial nerve stimulation is acceptable. In our guideline, it is positioned earlier in the algorithm, but in some of the international guidelines, it's positioned at this point. So any of these is fine. The first two would be the preferred answers. She elected to undergo botulinum toxin. What would you recommend as a starting dose? 100 units is now the guidelines recommended starting dose. What is the expected efficacy? So it does not work for everybody. That's the important thing here. So overall response about 60 to 70%. Any answer which is, let's say, between 50 and 80% should be fine. So it's not close to 100%. It's not like 20, 30%. It's about 2/3 of patients respond. But in terms of getting completely dry, again, completely dry, your answer should be below 50%. So about 1/3 of patients become completely dry with the injection. So this is important in the counseling, that your urgency will reduce. About 2/3 of patients, good chance. If you have severe incontinence, it's likely to become better, but may not go away. So unless you counsel the patient properly, you'll have an unsatisfied patient. What's the expected rate of urinary retention? This expected rate depends on the dose of botulinum toxin used. With the 100 unit dose, you expect a ballpark figure of 5% in a woman. Remember, we are talking of female patients. And if you have used 200 units, the ballpark figure is 20%. That's what we used to always quote. But the recent randomized trial, which I mean, not so recent now, randomized trial between botulinum and sacral neuromodulation, which used 200 units, actually showed a retention rate of 8%, which is why I've said any answer between 8% and 20% is acceptable for 200 units. But if we were just looking for 5%. So if you've written 5% or close to 5%, it should be fine. This patient had a partial response, continued to be symptomatic despite the botulinum. What next? Options, both these are acceptable. Increase the dose of botulinum with CIC if needed. That's an acceptable answer. Sacral neuromodulation is also an acceptable answer. Where will you position the lead? The lead is positioned at S3, and you can see here, as in this X-ray, the many methods of doing it, and I'm not going to go into the details, it's not really relevant, but you want to put it into S3. How do you verify that you're in the right position? This you can see here. There are two things. You look for the bellows reflex, which is when you stimulate, you get an indrawing of the pelvic floor, and you can see here the movement of the great toe in isolation, which tells you that this plantarflexion of the great toe, which tells you that you are in the right position in S3. Regarding nocturia, first question was, how do you define nocturia? There's a difference in that. There's a revised definition, which is why I brought this here. The revised definition is the number of times urine is passed during the main sleep period. Having woken to pass urine for the first time, each urination must be followed by sleep or the intention to sleep. So even if the patient doesn't go off to sleep again, that still remains nocturia. There is a gray zone here, and that gray zone is that in a patient who goes with the intention of sleeping in the night, let's say at 9 p.m. I decide to go to the bed to sleep, and then I'm not able to sleep because I keep feeling the desire to pass urine. Where does that fit in? So that's still a kind of a gray area, but you don't need to have the patient sleep each time before the next void to call it nocturia. How do you define nocturnal polyuria? ICS defines nocturnal polyuria in an age-dependent manner as greater than 20% of the total urine volume in a young person and more than 33% of the overall volume in an elderly individual. And remember, the nocturnal urine volume is all the nocturia urine plus the morning void. So the first morning void is added to the nocturnal urine volume, and then you divide the whole thing by the 24-hour volume. What are the two recommendations for this particular patient? Cut down fluids and use of OAB medication. We can see here the patient's mean voided volumes are also on the lower side. Alpha blocker is fine. Not acceptable is desmopressin. So of all the answers that you could give, if you see the EAU guideline, for instance, they allow you to use all the other medicines in a patient with bothersome nocturia. So if the patient has any element of voiding difficulty, add an alpha blocker. Patient has any element of storage symptoms, you can add mirabegron or antimuscarinic. So do everything before recommending desmopressin. So at this stage, for a patient who has such a large urine volume, desmopressin can cause trouble, should not be recommended. So that's not the acceptable answer. Everything else would be acceptable. State 3 causes of nocturnal polyuria. I won't go into the whole thing. I'll just leave this chart with you. So nocturnal polyuria can be fluid retention and mobilization related, altered ADH secretion related, altered atrial natriuretic peptide related, and because of fluid intake. So each of these, there's specific reasons. So fluid retention, mobilization, for instance, congestive heart failure or chronic kidney disease, altered ADH secretion just as a part of aging, ANP because of obstructive, not orthostatic, sorry, obstructive sleep apnea, and fluid intake could also trigger nocturnal polyuria. Let me go to the next question. What would be the approach? This is not a question, sorry. Right, stress incontinence, the next and the last one. So this woman presented with stress in clinical mixed incontinence. She has a dominant stress component with 2 of the 3 episodes as stress incontinence in the diary. And she also describes stress incontinence as a dominant symptom, and she has a stress test positive, but she does have urgency incontinence also. The first part was patient has not responded to conservative measures. What would be our next step? The answer is the next step would be to treat the urgency incontinence first. So regardless of whether the patient has dominant stress or dominant urgency incontinence, you always treat the urgency incontinence first as a principle, because you don't want to do harm to the patient. And any of these should be a fine answer. What is not acceptable at this stage is recommending urodynamics. So before in non-invasive therapies, you do not recommend invasive testing. Drug therapy is fine, invasive testing not fine, and stress incontinence surgery is also not fine. So if you answered urodynamics or stress incontinence surgery, that's not appropriate. The rest is all fine. So do not perform invasive testing before non-invasive therapy. She continues to have bothersome symptoms despite therapy for urgency incontinence. What would you recommend? At this stage, you would recommend urodynamics, because you want to check whether the patient's symptoms are because of uncorrected urgency incontinence or because of the stress incontinence. And how do you define? How do you make a diagnosis of intrinsic sphincter deficiency? Clinically, as well as by investigation. Clinically, it's by the empty bladder supine stress test. Ask the patient to pass urine, and after that, put her in the lithotomy position and ask her to cough. And if you get a little bit of urine leaking out through the urethra after she has emptied her bladder by passing urine, that's called the empty bladder supine stress test, a clinical stress test for intrinsic sphincter deficiency. ALPP less than 60 or less than 90, depending on the severity. MUCP of less than 20 or 40, or on clinical examination, if you say a fixed urethra, that's fine with a stress leak, except that that would be applicable only in limited clinical situations. But if you find a fixed urethra and the patient leaks and cough, that's also intrinsic sphincter deficiency, but it's not very common that you find that actually. We asked you in this, what's your diagnosis? You can see here the patient has a phasic contraction and leak, and also leaks when the catheter on stress testing with cough. So this patient has urodynamic mixed incontinence, detrusor overactivity incontinence, along with urodynamic stress incontinence. So that was the answer. This trace, the question was, what is your diagnosis? You can see here, after the cough, you get a triggered contraction each time. So this is cough-associated detrusor overactivity, which can be of different forms. You don't need to go into that right now. So a phasic contraction triggered by the cough, or CADO, cough-associated detrusor overactivity, which is the current ICS terminology for the condition. The last question, I think, was, or last or second last, was that this patient underwent a transobturator tape, presented with pain and voiding difficulty. And the question was, what would your next step be if this is the flow? So this is a slow, flat flow. The patient is passing urine very slowly. What would your next step be? The answer is that you would like to assess for additional complications before you do anything else. It's not common to get pain. So once there is pain, it's important to make sure the patient doesn't have tape exposure. So it's important to do a clinical examination, urine examination to see for microscopic hematuria, imaging to see the tape if possible, and a cystoscopy. So any of these would be fine to look for additional complications, specifically tape exposure in this particular patient. Any of these answers would be acceptable. And the last part was what are the two important complications you will discuss with the patient following for surgery. There are several complications where you excise the urethral and suburethral segment over tape. Uretrovaginal fistula and recurrent stress incontinence are the most important. Recurrent stress incontinence is not a given. So almost 50% patients will remain continent, 40%. Urethral stricture, residual tape fragments, development of diverticulum, unpredictable resolution of her pain, and urinary tract infections. With that, I end. I'm sorry I had to rush a little because we were really getting late with this, but I hope that we've been able to achieve what we set out to achieve. Back to Dr. Chawla. Arun, back to you. And let me ask Pawan, I see him there. Pawan, you wanted to make any comments, or Nikhil, you want to make any comments before I hand it back to Dr. Arun Chawla?
Sir, I'm good.
You want to add?
No, I'm good.
Can't hear you.
Sir, I'm good.
No further comments, sir.
Okay.
All covered.
Anyway, thank you very much, everybody. And when I say everybody, I mean first people who are part of our functional subsection. So Nikhil, Pawan, Anita, really you've contributed a lot. Arvind, Mayank, thank you so much for all the work that you do for the subsection. And of course, Keshav and Dr. Arun Chawla and Dr. Rajiv Sood, thank you all very, very much for giving us the opportunity to do this program. Back to you, Dr. Arun.
Thank you, sir. Thank you very much. I think the OSCE was excellent coverage of so many issues. You have very nicely, the questions were 9, but if you split these questions, there was so much of store of knowledge in that. You covered male LUTs, you covered neurogenic LUTs, you covered female storage symptom, voiding dysfunction, SUI, and very rightly the incontinence guidelines from the USI, and you were the lead in that. I think there were responses were a little less, but I think the questions framed were excellent, and this was one of the best OSCE session we ever had. The questions are crafted so nicely. It covered right from the simple questions, theoretical, practical, the office procedures, the clinical day-to-day cases which we deal with. So in short, a very well conducted program. With this, I'll hand over to Dr. Keshav and then Dr. Rajiv Sood for your closing remarks.
Thank you, Dr. Arun. I must congratulate Dr. Sanjay Sinha and his team for a great effort. It takes a lot of effort to do this OSCE and frame the questions and then come up with the answers and with the explanation. It was wonderfully done. Thank you, Dr. Sanjay Sinha, and all the members of the functional and the female urology section for a wonderful OSCE session today. Over to Dr. Rajiv Sood for his concluding remarks.
Thank you, Dr. Keshav, and especially big thanks to Dr. Sanjay Sinha and all the team, Nikhil, Pawan, and Mayank and Panda. Actually, this program, we are very happy that we are able to say this was the best program of the OSCE series. And last time also we were saying that this is the best program. And first OSCE was also we were saying that it was the best program when Raman was doing. So every time OSCE is improving, and we are, our mission, our dream is fulfilled by all these subsections. And Sanjay Sinha is always doing his best, and he's contributed a lot in the past also to USI, in the guideline cell of ISU also, and everywhere he excels in the specialty itself. Now, coming back to this OSCE, if 10 questions, 9-10 questions we keep on covering and we make it 150, and by that time, if residents and their faculty, their teachers, they take this program as very important program of education for the uniform education, which is the dream of USI, uniform curriculum. And I am again and again repeating, in this Diamond Jubilee celebration year of independence, when we dreamt in 2017 that in 5 years we will take the education of USI to the another level, and that will be the example for the entire world, that how the education is done. Earlier we were looking to other educational societies like AUA, EAUA for these efforts. I think you all will agree that we are doing with this cell-based functioning extremely well, and throughout the year we are doing. And the competency-based education, which I have been telling, this is actually 5 levels, and this is the first level, that knowledge. And then how? First level is knowledge, know, and the second level of competency is know-how. And that is what this OSCE is telling. We are explaining by this that how this knowledge is acquired, what is the reason. And then is the show, which is the workshops, and show how when the variations, controversy, everything we are discussing. And finally is the performance. We are preparing our urologists for the final show, final performance, and to be the global leader. And I'll invite all of you for the next level of Euromed programs, where we concentrate on performance in the simulation program, which is on 25th and 26th. Then we will be having our, as soon as the cadaveric open, the cadaveric workshops and wet labs, and then hands-on performances. And you know that 5 years back, we were depending totally on hands-on workshops or the workshops where the live workshops. So total atmosphere has been changed of urological education. I'm extremely happy as the chairman of ISU for this tenure. And these are the final stages where I'm so thankful to Dr. Keshav Murthy, with whom we dreamt when he was treasurer. And fortunately, he is the now secretary. And Nikhil, he worked with me for a very long time, and in the female urology, he was taking a lot of publications and interest and continuing. And most marvelous job, if we realize, is being done continuously by Dr. Arun Chawla, who is throughout these programs in these all the years for he is anchoring everything very well. Thank you, Dr. Sanjay Sinha, for this wonderful effort today. As usual, actually, words are, I'm failing in words in thanking all the faculty, especially this cell, our dynamic secretary, Dr. Keshav Murthy, and as I told, Arun Chawla. Good night for now.
Good
Thanks
night.
to all the residents also and the USI Central Office team. Thank you very much and good night. Have a wonderful week ahead. And again, we are meeting for more and more programs. And we will become the first association in the country who is giving actually competency-based education, uniform curriculum, uniform teaching, training, and taking this all effort to next level. Thank you. Good night.
Good.
Thank you, sir. Good night, everybody. Thank you. Thank you, Dr. Sanjay. Thank you, all the members of FFUSS.